a few words about borderline personality disorder in adolescents. That's true. I worked at the Institut Mutualiste Montsouris in Paris, but I also had the chance to practice research with Véronique Delven and other Maurice Corcos and Mario Speranza in the EURNET BPD, the European Research Network on Borderline Personality Disorder in Adolescents. And I will present a few considerations about the transition in borderline patients in the light of clinical and research experiences. Adolescents with BPD, borderline personality disorder, represent 40 to 50% of hospitalized patients in psychiatry, inducing a public health important issue. The use of mental health services among adult patients with BPD has been described to be more important than for major depressive disorder, for example, or other personality disorders. The transition between adolescence and adulthood in BPD is a striking transition in terms of prevalence. Indeed, the prevalence of BPD in adolescents has been evaluated between 6 and 18% of the general population, whereas 2% in adult general population. So it begs the following question: what do borderline adolescents become at 18 years old, or between 18 and 25 years old at the end of adolescence? We'll try to draw hypotheses in order to explain this clinical complexity. According to DSM-4 and DSM-5, BPD diagnosis can be applied to adolescents if the symptoms are pervasive and persistent for at least 1 year. 30 years of literature data on BPD in adolescents confirm that the phenomenology and comorbidity profiles of BPD are similar in young patients and in adults. That was what we also observed in the EURNET BPD, in this research network on adolescents. This literature data also confirm that BPD criteria may be observed in adolescents, are frequent at this age, and the clinic can be diagnosed with a strong reliability. Given this empirical literature, the diagnostic of BPD in adolescents has been considered as valid. For this reason, this diagnosis took its place alongside a large number of diagnosis categories from the DSM, for which the demonstration of a good reliability legitimizes its validity. But if we look in more details, one aspect of adolescent BPD validity is considered as weaker. It is the predictive validity of the diagnosis. Also, there is a scientific consensus on global validity, so a few authors have pointed out that the diagnosis failed to demonstrate stability over time. Some researchers have provided experience that diagnosis of BPD is stable across the adolescent developmental, with persistent rates of diagnosis between 23 and 33% after 2 years follow-up. In the EURNET BPD, we found a persistent rate of the diagnosis at 21% at 3 years of follow-up. These rates are relatively high for a psychiatric diagnosis, but are very low for a personality disorder, which is not supposed to be limited to a developmental period like the adolescence. However, according to the DSM definition of a personality disorder, the rates of remission of BPD in adolescents are even higher than in adulthood, and even higher than axis 1 disorders, like depression or substance abuse, for example. The predictive studies described that BPD diagnosis in adolescents seems to be predictive of various axis 1, axis 2 disorders, and serious functional difficulties, but doesn't predict specific evolution toward adult BPD, toward schizophrenia, or toward bipolar disorders. BPD in adolescents finally appears rather as an aspecific and transitory bottleneck of psychiatric pathology at this age of development. It probably certainly catches also other pathology like depressions, which take a borderline color at this age. And yet, the Personality Disorder Task Force of the American Psychiatric Association had questioned the concept and had been envisaging the removal of the diagnosis in the DSM-5. Finally, it has not been, BPD in adolescents has not been removed from the DSM, but this was in question. And particularly, this task force asked for a few arguments. They argued that the concept of BPD in adolescents did not apply to minors because they had not yet faced the basic task of adult life. And the second main argument was that BPD features were described as rarely persisting into adulthood. That is how the paradox of borderline in adolescence takes place. The diagnosis is valid now, but invalid later. Borderline adolescents are not doing well 2 years later, but they do not meet BPD criteria in most cases. One main clinical explanation of this fact is probably the difference of the internalized symptoms, like affective instability, which are durable, and externalized symptoms like self-injury, which are more visible and ask for a strong environmental response in adolescence, but are less durable through times. And in reality, suicidal injury, non-suicidal self-injury, or uncontrolled anger strongly diminishes over time. For all of these reasons, it would be more appropriate, effectively, to talk perhaps about to talk of a borderline crisis in adolescents in order to talk about the reality of these borderline features at this age without predicting anything about the adult's personality. Having said that, we experience the clinical fact that externalized symptoms are asking for an environmental response to an internal problem. Indeed, these BPD symptoms in adolescents often necessitate hospitalization and medication more than in adulthood in order to monitor the crisis and provide safety for these young patients who are at high risk of suicide. The unit BPD explored different environmental and psychopathological aspects of adolescents from 13 to 18 years old, like childhood trauma, life event, family psychopathology, etc. Adolescents were recruited through 5 psychiatric centers for adolescents and young adults in France, in Belgium, and in Switzerland, according to these DSM-BPD criteria. The sample comprised 85 BPD adolescents and 84 healthy control. The mean age was 16-year-olds. The research protocol consisted in a diagnostic assessment of axis 1, axis 2 disorders completed by a self-report questionnaire eliciting socio-demographic data, lifetime treatment use, several psychopathological features of interest in BPD, such as emotional regulation, impulsivity, attachment, traumatic experience, life events, parental bonding, narrativity, and so on. Our result about adversity factors in BPD strongly reinforced data about trauma history of a BPD patient. Within the life event BPD patient met, we can notice, for example, 20% of patients separated from a parent during more than 1 month before age on 1 year old, or 22% separated later from their 2 parents, either into foster family or into home placement. 21% of sexual abuse, 13% of emotional abuse, emotional neglect also, and physical abuse. When BPD adolescents described their parental bondings, they were in majority describing a parental link marked by a low level of care and a high level of control in parent-child interactions. Attachment evaluation showed that 75% of BPD patients had insecure attachment, whereas it was 30% in control group. And finally, 25% reported suicidal attempt in parents. And insecure attachment, together with parental suicidality, predicted BPD severity. So this result confirmed high level of trauma in borderline pathology. This result tells us that borderline adolescents are trying to cope with trauma. A prevalence of 20% of PTSD, post-traumatic stress disorder, comorbidity in our sample reinforces this assumption and reinforces the overlap between BPD and the notion of complex trauma. Ruptures, abuse, neglect are very frequent, and then the great priority, which is also different with BPD in adults, is the need to think about protection first of all. The psychiatrist has to make an exhaustive assessment of individuals as well as environmental factors implied in each patient. The time of hospitalization is often the time of this evaluation, regularly with the help of social services. Another aspect of the study was a qualitative investigation of the subjective experience of patients and controls about their childhood and their future. Face-to-face interviews were used to explore the adolescents' perspectives. They were based on 2 open questions. How do you remember yourself as a child? How do you see yourself in the future? This experience was based on the assumption that narrativity about one's childhood and one's future was a means of assessing to the experience of the self. Data were analyzed and showed that compared with control, BPD patients talk repeatedly about their pain and distress, expressing feelings of fear, sadness, and pessimism. The level of despair was heterogeneous, but reached heights such as described by one patient, who for the first question responded, an abyss of suffering. This is my life. But the most striking difference was the structuring of borderline discourse, with a great discontinuity and concerns centered on the present in a day-to-day experience of life. Sentences were short, a few isolated words linked without clear coordination with the rest of the discourse. The most interesting point was that borderline patients reorganized their discourse only when they evoked their traumatic experience. The second result concerned the relationship with temporality. There was a more frequent use of the present tense. Narratives did not use the difference between past, present, and future. When BPD adolescents managed to talk about their future, it was to talk about the contrary of their present experience. One main element of prognosis in BPD is represented by self-injury. And literature data showed that suicidal and non-suicidal self-injury were strongly linked with childhood sexual abuse. Many studies, including the Euronet BPD, reported specific links between non-suicidal self-injury and childhood sexual abuse. Thus, noisy behaviors of BPD adolescents may often hide the childhood sexual abuse. And the ignorance of these life traumatic events by the clinician is at risk of a traumatic repetition and a lower prognosis in adulthood in this patient. Our experience reveals that BPD patients, by accumulating sexual abuse and emotional abuse, are often not believed by their parents when they revealed their sexual abuse. And this fact is enhanced by a transgenerational traumatic experience of parents, which is repeating. The prognosis of BPD is thus strongly linked to the way childhood sexual abuse is managed through medical care, prevention policies, or appropriate judicial procedures. These are fundamental conditions for BPD transition. The omnipresent and cumulative place of adversity in adolescents with BPD invites clinicians and researchers to systematize childhood adverse experience investigation in patients with BPD features. For example, the presence of self-harm behaviors should consistently orientate the clinician toward investigating sexual abuse particularly. Moreover, our findings argue for prevention policies and treatments in BPD focusing on a close articulation between child psychiatric and child protection services on one side, and also with adult psychiatric services for parents and on the other side. Moreover, there are significant implications of these findings on the psychodynamic treatment, including the possibility that trauma-focused psychotherapies may take a significant place in BPD trauma in adolescents. The organization of preventive strategy should help the primary caregiver to provide continuity of care and security for children regarding the high frequency of low level of care and early separation from caretakers in BPD. Statistic on attachment with 75% of insecure patients confirms one of the most evident clinical facts in borderline pathology. The most important is to develop a safety basis, a safety frame. Sometimes this basis is the whole institution or the crisis unit first. In the less severe cases or in the course of the disorder, the referred psychiatrist may then take this function. In conclusion, once the suicidal risk has been passed, BPD in adolescents is very severe, but prognosis is rather favorable. Adult guidelines for BPD cannot be applied linearly to minor patients. The need of protecting borderline adolescents from abuse, neglect, and ruptures is the priority, as much as helping parents to cope with an escalade of violence, also generated by the symptoms of their child, and also linked with their own traumas. Adolescents with BPD need more continence and more hospitalization than adults in order to begin recovering of trauma. The UNED BPD revealed that adolescents had met 5 or 6 psychiatrists at 16 years old. This is a huge fact because this is also due to their insecurity and they repeat ruptures. And the main aim is to stay as one psychiatric stable over time. They first need a solid frame, then psychotherapy may begin when this frame has been repeatedly tested first. The day before yesterday, I talked to a patient, a borderline patient, and I told her I came here and I asked her, what could you say about transition between your adolescence and your and now? And she responded, because I've been treating her since for 5 or 6 years now, and at the beginning of her medical care, she was many times hospitalized, and then after many suicidal injuries, suicidal attempts, etc., addiction, cannabis, cocaine, suddenly her father died, and she fell into prostitution. And the year after, she recovered with an incredible resiliency. She went back to school after 4 years of symptoms, and then to university. And now she advocates for women's rights and for ecological transition with stronger emotions. And now only now, after 5 years of medical care, she is ready for a psychotherapy, to begin a psychotherapy. But all the time before, we were doing psychotherapy, but not in the classical form. So she responded, whatever I have done during all these years, I knew that you were here in your office. I could do anything, stupid things, or I didn't remember all the things I did, but you were still here, and I knew that there was someone here and now with projects for me in mind, so I could come back. And then now this is for me the image of a transition. I thank you for your attention.